We're honored to have Paul Saraja with us, who's been a longtime Mayo person, is now just up the street at Minneapolis Heart. He's an expert angiographer and really a master of hemodynamics. I think many of you might have met him late yesterday afternoon at the hemodynamics session. So we'll go ahead with angiography coding.
Almost echo coding. Thank you very much, Kyle, and good afternoon to all of you. So in the next hour, we're going to be spending time doing angiography coding. For those of you who work in the lab or will have a career in the cath lab, some of these aspects may seem quite basic to you, and I am taking a basic approach because on the boards, the angiography coding has become quite elementary and somewhat basic too. So this should be all that you need to know, and certainly I'll be available after this presentation for any questions. So here's a strategy for coding angiograms. I'd recommend you start by getting oriented to the view, and the way I would think of this is it's very similar to a chest x-ray. With a chest x-ray, you want to start with AP or lateral. In the cath lab, looking at an angiogram, you want to start REO and LEO. So that's the first question you should ask is which view is that? Other things to consider is not to overread, particularly for the boards. There are not going to be any trick questions. Use your non-cardiac cues, especially those vignettes. There'll be clues about what you should code in the vignette. And then also know what normal is, and we'll be looking at some normal angiograms. And by understanding what normal is, you will understand what abnormal is. So let's first start by getting oriented. So the first question again is REO versus LEO. And the way we decide REO versus LEO is to look where the ribs and the spine are. So in the REO projection, the camera is on the right side of the patient and it's shooting across the right side or the left side of the patient's anatomic left chest. As a result, the ribs will be on the left side, the spine will be on the left side of the screen and the ribs will be going down to the right. So remember, spine on the left, ribs going down to the right, right anterior oblique. Conversely, if you have an LEO projection, as one sees here, the camera is on the left side of the patient, and as a result, the camera is shooting over the right half of the patient's chest. The spine will be on the right side of the screen, and the ribs will be going down to the left. So spine on the right, ribs down to the left, LEO, or left anterior oblique position. Now, the reason why this is helpful is because if you know whether you're REO or LEO, you immediately know which walls of the heart you're looking at. So here, this is an LV gram, and here, this is an REO view. See the catheter there? The catheter is in the descending aorta, which is against the spine. So that means the spine's on the left, ribs going down to the right. This is right anterior oblique. Walls of the heart here will be anterior, anterolateral, apical, inferior, posterior. So if I take this LV gram away and you're left with just these shadows, again, this is REO because ribs going down to the right. These are the walls of the heart that you would expect to see when you do your coronary angiogram. Now, once you know what the walls are, you then know what the vessels are, because the anterior wall, as we all know, is supplied by the LAD. Anterolateral is a diagonal branch. The apex, most of the time, is supplied by the LAD, and the inferior posterior area will be your PDA. So again, just knowing the projection and knowing where the walls would be, you will know what vessels should be in those areas. Now moving on to the left side, left anterior oblique. Spine here is on the right, ribs going down to the left. Here in this projection, the camera is shooting right into the patient's heart. This is the anterior wall, this is the inferior wall, ventricular septum, and lateral wall. So once we know those are there, we can again take that LV gram away, and we would know that the walls of the heart would be in this configuration. And by knowing that, we also know that any vessel up here will be the left main LAD, which normally courses over the ventricular septum. The right coronary would be over the RV, which sits over here. The lateral wall would be the left circumflex, and the PDA would supply the inferior wall. So, know the view, then you'll know what walls you're looking at, then you'll know what arteries you're looking at as well. View, walls, artery. So let's look at some normal coronary arteries. So here's a picture of a normal right. So spine is on the right, ribs go down to the left, so this is an LAO view. This is a right coronary artery coming around and supplying the inferior wall. Here's a left coronary artery. This is supplying the lateral wall and then goes down to the inferior wall. The first question you should ask when you're looking at the inferior wall is, what is the dominance? Because the dominance will help tell you whether to code that inferior wall and the pathology there in the right coronary artery or in the circumflex territory. Most of the time, we're right dominant, and that's usually defined as the PDA supplying the inferior wall. Other definitions also include the AV node branch, but for the board purposes, I would just focus on what vessel supplies the PDA, whether it's the right or whether it's the left. And the easiest way to see this is in the LAO view, but you can also see this caudal-cranial, because remember in this projection here, this is always going to be the inferior wall. This is the caudal projection here, and if I go cranial, that still is the inferior wall. So you can see here, this is a left circumflex coming down here, supplying that inferior wall. That's a left dominant PDA. Here's a view of the left using an REO projection. Remember, when you're up at the cranial side, this elongates the LAD, but the relationships still remain the same. This is the anterior wall. Here in the caudal view, the camera's coming down towards the patient's feet, and this is the circumflex here supplying the lateral wall in this area. Here's another view of the left coronary. This has gone LAO. So spine is on the right, ribs going down to the left. This is the left main. This vessel, which is up here, must be the LAD. It's going towards the ventricular septum, as you see here. This wall of the heart has to be the lateral wall of the heart, so this vessel must be the circumflex. That relation remains the same whether you go cranial or whether you go caudal. We go caudal here. All that's happened is that the camera is tipped down underneath the heart, so we're shooting up through the left main in its bifurcation. But this is still the anterior wall. This is still the ventricular septum. So this is still the LAD and its branches down here. And this is still the circumflex because this is still the lateral wall. So again, no REO versus LAO, and you will not get tripped up as to which walls you're looking at. So look here. So which one of these is the LAD now? And I want you to look. This is an REO projection. This is a left coronary artery. And there's a branch here that looks like it's going along this surface and a branch that's coming along down in this surface. And the teaching point here is that the LAD is B. And the reason why you know that is because the LAD moves in an opposite direction in relation to all the other branches that you see here. And the reason why that happens is because when the heart beats, if you look from the head towards the feet, it beats in a clockwise motion. So everything that's on top of the heart will move down, and everything on the lateral walls of the heart will move in the opposite direction. So we know this branch here, right here, this is moving with the circumflex, so that must be on the lateral wall. And this branch, which is moving down with each beat, opposite the circumflex, must be the LAD. And that becomes very important in STEMI patients when you have occluded branches and you wonder whether or not the LAD are diagonal or open. So look at the movement for wondering which one is the LAD. They're going to be opposite. Here's some views, again, of a right coronary artery that's normal. This is an REO projection. This clearly is right dominant. It's going to the inferior wall here. Here's an LAO projection going over the RV, supplying the inferior wall. Now I want you to get your clickers out and help me decide, where is this bypass graph going? A, B, or C? Okay, so the correct answer is B. So this is a circumflex graph. Now how do I know that? Spine is on the right, ribs going down to the left. This is an LAO, left anterior oblique projection. That means that this wall is the anterior wall, this is the inferior wall, This is the septum. This is the lateral wall. Graft to the lateral wall is a graft to the left circumflex. So use those projections and know where those walls are, and that will tell you where the grafts are. Let's look at another one here. How about this one? Where is this bypass graft going? Excellent. It's perfect. I think you all got this. So REO view. So this must be the anterior wall. This is also going down to the apex. So this bypass graft is an anterior wall graft, which should be the LAD. That's correct. Anterior apex inferior. And again, it can be helpful to look at the movement, which you might see. This is beating down with each beat. That's the LAD graph. How about this one? Excellent. So this is a bypass graft. It's the LEO view. It's going to the inferior wall. So then the next question is this left dominant or right dominant? Because if it's inferior wall and left dominant, you would code circumflex. But this is clearly right dominant, and you know that because you can see the native right coronary artery filling retrograde here. So this is a right dominant circulation graft to the right PDA. So know the view, know the walls, you'll know what arteries you're looking at, and then you will know where the grafts go. Okay, how about this? Where are the collaterals? So the correct answer is A. So here's the coronary catheter. It's pointed towards the patient's anatomic right. So that means it's injecting dye into the right coronary artery. So when we inject the right coronary artery, we should not see anything over here on the left. But here in this LAO view, we know that this is the anterior wall, this is the ventricular septum, the lateral wall will be over here, the inferior wall will be over here. So by injecting dye through the right coronary artery, there are these little feeder branches that are coming up and supplying the anterior wall and the ventricular septum. So these are collaterals to the LAD. And there's a view of the collaterals. And here's a live video. So you may get videos, you may get stills. I think it's probably a little bit easier to see with the video here. And again, look at that movement. Look at the movement here of the LAD. You can see it's when it pans over, it's beating down with each moment. Very little doubt that's the LAD here. How about here? Are there collaterals here, and where would you see them? Excellent. So these are circumflex collaterals. So this one's a little bit more difficult, but what I want you to see here is that in nature, vessels should not cross each other. And you can see here, this is a vessel that's crossing the LAD. This is the circumflex. It's coming down here. It's occluded. And this is a collateral from the LAD to the circumflex going via a diagonal branch here. And there's the collateral that most of you picked up. And here's what it looks like. This is before PCI, and then with PCI, you can get an idea of how that vessel looks. So again, remember when you see collaterals in the inferior wall, don't automatically assume that it's a right coronary artery in terms of the collaterals. Whenever you're coding the inferior wall on the boards, next question you should always ask is, what is the dominance? Because that's one area that they can trip you up in terms of what to code in the inferior territory. So look at dominance when coding anything in the inferior wall. So know the view, know the walls, know what your arteries are looking at. That will tell you where the bypass grafts are going, and that will also tell you what the collaterals are doing as well. So let's move on now to coronary anomalies. So you should suspect a coronary anomaly anytime there's a history of sudden death, or if you have an artery that has a long branchless origin. And the key to understanding anomalies is to ask two questions. First, is the anomaly coming off the left or the right cusp? And secondly, is the immediate course of the anomaly going anterior or posterior? If it's going anterior, it's going to be going between the great vessels, and there's a greater risk of sudden death or ischemia. Otherwise, if it's going posterior, it's generally felt to be a benign anomaly. So let's go about how do we address those two questions. So here, remember that when we look at left versus right, this is easiest to see in the LAO view. Spine on the right, ribs going down to the left. This is left anterior oblique. For anterior posterior, we want to use the REO view. REO view gives a better idea. This is posterior and this is anterior. So this is what it will look like. So here's a root shot to help you. Again, left versus right is going to be with LAO. Anterior versus posterior is going to be REO. Now, again, if we look at the relation between the aorta, as one sees here, this is where the normal origin of the arteries would be in this scheme. So this is the right, patient's anatomic right, and this is looking from the foot of the patient. This is the right coronary artery here. Here's the left coronary artery. Here's the pulmonary artery up here. So if we have an artery that goes posterior originally, it's going to be generally benign, whether it's coming from the right and going towards the left, or if it's coming from the left and going towards the right. If, on the other hand, we have an artery that's coming from the right and it's coursing anteriorly initially, it's likely going between the great vessels and it's likely a significant anomaly. Similarly, if you go from the left and going anteriorly originally, it's going to be a greater likelihood of causing ischemia or sudden death. So that first question should always involve left versus right, and then the next question is anterior versus posterior. So let's look at this one here. Here's an example. This is the LAO view. Spine's on the right, ribs going down to the left, left anterior oblique. The catheter is pointing towards the patient's anatomic right. And we have here this artery which is largely long and branchless, and it's coming over and supplying this area. So now that we know what the walls are, because we know what the views are, we know that this vessel has to be the LAD. So we've got an anomaly going from the right and supplying the anterior wall or the LAD. So this is a left to right LAD anomaly. We then go and look in the REO view. And in the REO view, remember, this is anterior, this is posterior. So one can see here that the initial course of the artery is going posterior. So it's going around the aortic root and then going anterior. So the way we would read this, right cusp anomaly going to the LAD, and it's posterior in its origin. So it's a benign anomaly. And if we were to do a CT scan, this would be read as a posterior LAD off the right cusp. Here's what it would look like on a CT, be coming off the right, going posterior, and then going towards the patient's left to supply the anterior wall. So this would be felt to be a benign anomaly. Let's now look at this one. So again, LAO view, and look at this catheter, which is pointing towards the patient's anatomic left. It's actually filling part of the left coronary artery here, but it also fills the right coronary artery. So we've got a right coronary artery coming off the left cusp. It's going rightward over here, over the RV. So anomalous right off the left. We then go to the REO view and look at the initial course of the artery, and one can see here that the proximal portion of the artery is going anterior. So that means that that proximal portion is going between the great vessels and is likely causing ischemia. Another clue here is that these rights, when they come off the left, they have this very characteristic slit-like appearance, and that's because these orifices, you can imagine how they're canted rightward, and they have this very slit-like origin. So this would be considered a malignant anomaly. So here's how it would be read: a right coronary artery off the left cusp, and on the CT study, it would look something like this, coming off the left coronary artery, coursing anteriorly between the great vessels. Here's another one. So LAO view here. We know that this wall must be the lateral wall of the heart. So this vessel must be the circumflex, and it's supplying the inferior wall because this area is the inferior wall. So this is a left dominant circumflex. But the interesting thing about this artery is that it's very long and branchless, and it's originating in the right cusp. So this is one of the most common anomalies, and I suspect you will see this on the boards because of how common it is. This is a circumflex coming off the right artery, and it's posterior because we look here in the REO view, and the initial course of this is posterior around the aortic root. Now, some physicians have talked about using the dot method, so you might have heard this in your lab. The dot method just looks at the radiodensity from the dye being on top of itself, and if you've got a posterior dot, as you see here, that's considered to be benign, whereas if you have an anterior dot, it's considered to be malignant. And I would just focus on more of the fact of whether the initial course is going posterior or anterior, because that course will tell you whether or not it's benign or malignant. So here, posterior circ off the right, and this is how it would look like on CT scan coming around here. Let's move on to some other pathology. So atherosclerosis, I think most of you know this already. Just a few tidbits. The stenosis severity is relative to the proximal vessel. It will not be vague. They will not ask you to code 10 versus 40 or 40 versus 60. It will be quite obvious in terms of the significance of the atherosclerosis. You should look for stumps. Be sure that if there are areas where there's radiolucency, that it's not because there's an artery that's blocked in that area, and always code the worst lesion for the vessel. So I think most of you have seen these before. So complete occlusions. Here's a left main complete occlusion. Here's a circ that's completely occluded. Here's some mild disease of the right coronary artery, and here's some severe disease of the LAD. Again, it will be pretty clear. It will not be vague in terms of your ability to code these lesions. Thrombus. Look for the historical clues. They almost always will give you a scenario with an acute coronary syndrome. On the angiogram, look for hang-up in the dye. Look for staining because acute lesions stain and have dye hang-up. And look for flush occlusions with hazy stents. So here's an example of thrombus. This is a right coronary artery, inferior STEMI. You can see here this dye hang-up, this hazy stump. This would be coded as complete occlusion of the right coronary artery with thrombus. Here's some other examples. This is an LAD occlusion, a hazy stump in this area. Here's a vein graft occlusion. Again, just look for those and think of those vignettes too in terms of coding thrombus. Dissection. This is an example of dissection. So it's often described as railroad tracks through the arteries, and you can see here because of the multiple planes for the dye to travel through. I would have a very high suspicion for dissection if there's anything in the vignette about somebody having had normal coronary arteries really proximal to the angiogram, or even in the same study. You might hear something about a difficult angiogram, difficult catheter engagement, suggesting that there may be a proximal dissection in the vessel with the guide or diagnostic catheter. And also be very vigilant about peripartum women. If there's anything about peripartum women, look for spontaneous dissection, which is more common. Some of you may have also heard of the recent association between fibromuscular dysplasia and SCAD, or spontaneous coronary dissection. Look for connective tissue disorders that also could be related. It will be reasonable to code thrombus with dissection. They almost always go together. And also think of dissection after intervention with PCI. So here's an example. This is a case of one of my partners. And you can see here this is a right coronary artery injection, which looks pretty normal. But then within a half hour, she starts complaining of chest pain and the vessels occluded. So this was a difficult angiogram. And this is a coronary artery dissection involving the right coronary artery. Again, normal coronary arteries, newly occluded. Be very suspicious for coronary dissection. Coronary spasm, this can be considered only when there's drug intervention. You have to see the dynamic changes in the vessel with some type of drug intervention. Otherwise, it's very hard to code coronary spasm. So this is an example of an LAD in which acetylcholine was infused, and there's intense vasoconstriction here consistent with diffuse coronary artery spasm. They might show you this, and they might show you a picture after nitroglycerin. Think of spasm if you have such patients. Myocardial bridging, it's very common in patients with hypertrophic cardiomyopathy, much less common in the general population. They must show you the presence of the bridge in systole and diastole. It's kind of like spasm. They have to show you before and after. They can't just show you a still image. So consider this if you see dynamic changes, but there has been no drug intervention in your patient. Coronary aneurysms, this should be considered whenever there's a vessel that's about 1.5 times the diameter increase of the segments on either side. They can be congenital or acquired. The most common reason for aneurysms are atheroma. Also think of these with Kawasaki disease, connective tissue diseases, arteritis. Sometimes it can happen with physiologic adaptation, but that's quite rare. These can lead to thrombosis, ischemia, emboli, and almost never rupture, though it's been reported. Here's some examples of aneurysms. This is a fusiform aneurysm of the right coronary artery. Here's some saccular aneurysms of the LAD, and here the proximal right. If you see a saccular aneurysm, think of sepsis and think of endocarditis in your management. Cornea fistulas, they can be acquired or congenital. They occur pretty much with the same frequency from the right or the left, and they can terminate anywhere, but usually in the right side of the circulation, RV, RA, pulmonary arteries, or the cornea sinus. And most of the time, cornea fistulas are asymptomatic, though there are reports of patients with steel and ischemia. When you see something outside the cardiac silhouette, you should start thinking of whether or not those are bypass grafts or whether those are fistulas. Here's an example of a fistula from the right coronary artery to the PA up here. Here's an example of a fistula from the LAD to the PA. And this is perhaps easier seen with the video, but just think of fistulas when you see small branches outside the cardiac silhouette that are not due to bypass grafts. Here's an example of a giant fistula. It's pretty hard to miss this one. This is a right coronary artery which has become very large and emptying into the coronary sinus. This one was surgically managed in our practice. So for the coding sheet, I apologize, this is 2015. It has not changed from last year. The nice thing about this session in terms of the angiographic coding is that there are no longer aortograms or ventriculograms. These images, however, might appear as part of other questions, so I just want to spend a little bit of time looking at some aortograms and ventriculograms. Remember that with a normal LV, you should have good wall motion. You should look for a very typical cavity shape, and then you should also see dye only in the LV and only in the aorta. If you're injecting in the aorta, you should only see dye in the aorta. You might be shown some evidence of hypokinesia and hyperkinesia. These will be shown with images side by side. In hyperkinesia, you'll see small cavities in systole. Here's an example of some pathology you might see here. Again, this might be part of a vignette. This is a pigtail catheter in the LV, and if you look carefully here, there's dye coming over from the left ventricle to the right ventricle. So this is a VSD. That one's quite dramatic, but they might be a little more subtle, as one sees here. Just a little trail of blood here. So if you have an appropriate vignette and you see a video like this, look for VSDs and just be sure that all the dye is staying where it's injected. Aneurysms also might appear on the board exams. Remember, true aneurysms involve all walls of the heart. There will be some akinesis or dyskinesis. They can be apical. They can be involving the anterolateral wall. So look for those aneurysms. They can also be posterior basal, as one sees here, or apical. A pseudoaneurysm is different from a true aneurysm. These have narrow necks. True aneurysms have wide bases, so these are contained ruptures. So here's some examples of a pseudoaneurysm. This one's in the apex. This is in the posterior base of the heart here. Here's an example of a nice LV-gram showing apical hypertrophic cardiomyopathy. In this view, one can see that in diastole, that the heart or the dye is not fully expanded, and this is because this whole area of the apex has left ventricular hypertrophy. A little bit easier to see with a video, but if they show you this still image of a spade-shaped configuration, think of apical hypertrophic cardiomyopathy. Here's some examples of thrombus. So this one here is a mural thrombus in the apex. You can see this kind of hazy area with akinesis of that segment. They'll give you some vignette that will suggest its presence. This one is a little more ball-like, but again, it's in the akinetic area of the apex. And this is one that you probably would recognize just by looking at the LV-gram. If you get a vignette with apical wall motion abnormalities, some history of stress, female gender with normal coronaries, this is a very good example of stress cardiomyopathy or Takotsubo cardiomyopathy. So this hyperkinesis of the base of the heart with apical wall motion abnormalities. So just a couple things about regurgitation. You won't need to code regurgitation, but you may need to be familiar with Seller's criteria. It's 1 through 4. It's based on the degree of filling of the chamber, so a partial fill versus a complete fill, and then whether or not the density of the dye in the regurgitant chamber reaches that of the chamber that the dye is put into. If it's the same density within 4 to 5 beats, it's grade 3. If it's 3 beats or less, it's grade 4. And these criteria are the same whether it's AR or MR. So here's an example of some regurgitation. Remember that there should not be dye posterior to where the chamber is being injected. The catheter is in the LV, and dye is moving back towards the LA. And again, you won't need to quantify the degree of regurgitation, but just be aware if they show you this, that may be what they're trying to show you. Here's an example of AR. So remember, here's a catheter in the aorta. Remember that dye should stay in the aorta. It should not go into the LV. If you see an aortogram like this, it should actually look like this instead. Here's some examples of aneurysms that they might show you. Here's an aneurysm of the root. There's another root aneurysm. One thing to keep in mind is that, remember, as we get further from the root, the vessel should get smaller and not bigger. Here, this one gets bigger and then gets smaller. I believe Dr. Sabako will show findings of coarctation in her session. Here's an example of an aortic dissection with dye hang-up. One other thing you might see, this is pericardial disease. So this is a right coronary artery injection. One can see here that there's a lot of pericardial calcification, and it's actually quite common for these patients to have epicardial fixation. So if one looks here, this is easiest seen in the REO view. Last night you may remember that Sunil mentioned exaggeration of this longitudinal movement of the base. So that movement gets exaggerated, but then the epicardium gets fixed because of the constriction. So you might see this epicardial fixation in a patient with pericarditis. So let's just look at a few more case examples. and I want you to look at this image and just kind of think of what you see here. You don't need to get your coding sheet out, but just look at this. It's an LV gram, and this is an aortic aneurysm. So here, the root is getting bigger as it's getting further out, so it should get smaller starting at the root here. So this is an ascending aortic aneurysm. Here's another case that you might see. This is apical hypertrophic cardiomyopathy with an apical aneurysm. So again, in diastole, that dye becomes spade shape, and that's because of the thickness or hypertrophy of the LV. In this area, there's an old infarction with an apical aneurysm here. And then finally, here's another one that you might see. There's an aortic prosthesis here. We're injecting dye in the LV. And again, if you got some vignette of a murmur, you would think of a VSD, and that's what this patient had. This patient had a perioperative VSD, membranous VSD related to the surgical AVR. So if you have your coding sheets out, we're going to finish by coding a few angiograms. And we'll start with this one. I'll give you just a few minutes to think about what you see here. So some of you might be wondering, is this LAO, REO? And this is actually almost an AP view. And I know this because the spine is essentially in the middle of the screen. But I think even that, you should still be able to tell where this graph is going. Because here in this view, this is going to be the anterior wall. This is going to the ventricular septum. This is a circumflex. This is the inferior wall. So this is a bypass graph to the LAD. And if you wanted to code severe stenosis of the LAD, you would be correct here as well, because there's retrograde filling, but it does not fill up much of the vessel, and we would also suspect the graft is put in there because of stenosis. In this view here, this is a view taken after this view, and here we have a dissection of the Lima artery. So this is a dissection of the Lima graft as well as the other elements that we would code. Let's look at this one here. So this on the left-hand side is an LAO view. We have the catheter coming up along the spine. The ribs are going down on the left. This catheter is sitting in the right cusp. However, the artery that it's being filled is the left coronary artery. We know this because this is the anterior wall, this is the lateral wall, so this is the LAD, this is the circumflex. So this is an anomalous left coming off the right cusp. So the first diagnosis is anomalous left coming off the right cusp. We then go to the REO view, and we see that the initial course of this artery is anterior. So this is a malignant anomaly going between the great vessels and the heart, and most likely causing ischemia. Now the other things that will also be coded are some mild disease in the circumflex and some perhaps moderate disease here in the LAD. A little hard to tell here. I put this in here mainly for the anomaly. Again, when you're coding stenoses, it would be quite clear in terms of severity. Some of you might have coded some disease in the ostium of the left main. That's not unreasonable. See this artery, it actually gets a little bit bigger before it gets smaller. So that would also be reasonable to code mild atherosclerosis there. But the key point that I wanted to make here is anomalous left coming off the right coronary artery. Let's look at this one here. So in this view here, this is the LAO view, ribs going down to the left anterior oblique. This is a picture of the right coronary artery, and the reason why this is being shown is to show you that this is a non-dominant right coronary artery. It's not going to the inferior wall of the heart. Here, this is a picture of the left coronary artery. This is a right anterior oblique view because the ribs are going down on the right side of the screen. There's a lesion here in the proximal segment of the LAD, which is severe. This is the anterior wall, LAD here. There's also complete occlusion of the circumflex, which one sees here. And then there are also these collateral branches here. And these collaterals, which are inferior, because remember, this is the inferior wall of the heart, these are left PDA collaterals. And we know that because this is a non-dominant right coronary artery. So these PDA collaterals have to be originally from this left circumflex. Move on here. So, LAO view, spine's on the right. This is an LAO view. This is the anterior wall. This is a ventricular septum. The lateral wall is over here. This is a bypass graft, and there's a severe lesion in the bypass graft going to the LAD. Now, it's very helpful to use both the still image and the video here. And the reason why is I suspect some of you might have been wondering, is this a lateral wall graft or is this an anterior wall graft? So if we look here, this graft is coming along here, and look at that motion. And remember what I said about the LAD and how it twists downward with each beat? This LAD, the native vessel, is twisting downward with each beat. So this is clearly a bypass graft to the LAD. So use that movement to your advantage, and you'll know that that graft is going to the anterior wall and going to the LAD. So we code severe disease in the graft to that vessel. We'd code severe disease in the proximal segment of the LAD. We'd also code collaterals to the right, as one sees here. You can see these collaterals coming over here. This is the right ventricle in this area. And I don't know if you would need to code disease in the right coronary artery, presuming it's a severe disease because these collaterals are present. I certainly don't think you would be dinged for it either way. It would be reasonable to put something down, but we're not showing you the right coronary artery per se. But you can presume that the right has severe disease. How about this one? A 60-year-old man with a recent PCI of the LAD then decides to have gallbladder surgery. I apologize if this is somewhat hard to see, because it's hard for me to see from this point of view. But what we have here is the right anterior oblique view. This is the anterior wall. there's a subtotal occlusion of the LAD, and it's right in the area where an old stent is, so that stent would be coded as not being patent. This is stent thrombosis and non-cardiac surgery after PCI. And I know this is the LAD because, again, this is the anterior wall, this is the apex, and that movement of the LAD beating down with each heartbeat. Use that to your advantage again. How about this case here? So this is a left anterior oblique view. This is a bypass graph, which is coming down and supplying the inferior wall. There's a lesion in that bypass graph. The bypass graph is going to the right coronary artery because I can see that there's retrograde filling of the right coronary artery, and thus this is a right dominant circulation. So severe disease here, severe disease in the right coronary artery, and bypass graft to the right coronary artery. Let's look at this one, a little bit more challenging. So this is an anomalous left coming off the right. So ribs going down on the left. It's a little bit hard to see here, but the spine here is on the right-hand side, so this is an LEO view. The catheter is pointing towards the patient's anatomic right, and it's actually filling some of the right coronary artery, which one sees here. This vessel is clearly supplying the lateral wall of the heart because we know this is the lateral wall of the heart and the LEO projection. So this is a circumflex vessel coming off the right coronary artery. So that's the first thing I want to emphasize. The second thing I want to emphasize is this stump here. So again, look for those hazy stumps here. We could have given you a clue of a vignette of a patient with an ACS, but this is a stump, this is a complete occlusion. So if you see an area where there aren't any vessels, again, look for stumps and complete occlusions. If you wanted to code some atherosclerosis in the right coronary, I think you can. This is not a dedicated picture of the right, so I would not use this picture to code the degree of atherosclerosis, but certainly there is some here that is of indeterminate severity, at least at this point, I would say. So look for those stumps there. How about this one? And I'll play you the video on the right after we code this first one on the left. So the main point of this one is to make sure you see that the left LAD is completely occluded and there's a stump here. So all the vessels here are moving in the same direction. So before anyone confuses this vessel for being the LAD, these are all circumflex vessels because they're all moving in the same direction. Here's a picture of the right. And one can see here, here's the LAD. See how the LAD is moving opposite of all the other vessels? So this is a collateral to the LAD. Okay. How about this one? So this one is a bypass graft to the right. It's a very short bypass graft, but the main thing I want to emphasize here is that bypass grafts will not have branches and they will be outside the cardiac silhouette. So before anyone confuses the native right versus a bypass graft, first determine whether or not it's outside the cardiac silhouette. And here in this video, one can clearly see that this is coming down an anastomose to the proximal right, and the native coronary artery is actually filling retrograde and emptying to the root here. What also is helpful here is that the aortic valve has been replaced, and so you know the aortic root is in this area, and this origin is too far from this aortic valve to be the native right coronary artery. So just use all the clues. Again, remember what I said about using all the clues in your picture to help decide what's present. So you would code bypass graft to the right coronary artery, severe disease in the right coronary artery as well. And if you wanted to code some mild atherosclerosis in the graft, that would also be acceptable. 72-year-old woman with an elevator troponin. So this would be a severe lesion in the right coronary artery. You do see flow, so I would not code this as complete occlusion, but I'd say it's severe lesion, and this is likely also thrombus, especially with a history of positive troponin. This is the right coronary artery, we know, because this is the LA view, the ribs going down on the left. This artery is in the patient's anatomic right cusp, going over the right ventricle and supplying the inferior wall of the heart. So two more cases here. So this is a picture of the patient's right coronary artery. This is an LAO view, vessels going to the patient's right. There's complete occlusion here with what we call bridging collaterals. So these are right-to-right collaterals, these little feeder branches here. We'd code complete occlusion, collaterals to the right. We'd also code aneurysm and ectasia in the proximal segment, given this finding here. And the last case here, 32-year-old woman with chest pain who's 1 month postpartum. So this is a right anterior oblique view, spine on the left, ribs going down to the right. So this is the anterior wall. Because this is the anterior wall, this must be the LAD. And what you can see here is these tram track appearance of the LAD in the setting of postpartum with chest pain. This is spontaneous coronary artery dissection. You can see the whole LAD in the distal segment has this dissection, and it'll also be reasonable to code thrombus here. So that's all I have for you, and I wish you the very best of luck. Thank you.